prevention in the United States. That's basically data-driven national objectives in the United States. And there's over 350 different areas that they've set goals for us in the US. And one of those objectives was to lower preterm births to no more than 9.4% of live births in this country. Next slide. And it's interesting to see, as you can see at the United States rate, we did drop close to 9.3, 9.4 back in 2014, kind of hovered around that mark, but it has gradually increased since that time. So we've gone back up. Now, the next slide shows you where we are in South Carolina, and we're doing even worse. We're at 11.8%. So our March of Dimes score is a grade F. And to take it to the next slide, breaks it down on county level in South Carolina. And you can see, at least here in the Midlands, the middle light green is the 11.3 to 12.8%. And then we go from a low in the upstate of Pickens at 9.3% to a high in McCormick County of 15%. So it's variable, but frankly, all across the state, we are higher than that national objective that we tried to are trying to strive for. Next slide. So one of the things that we know, and you guys all know this, the risk factors for preterm birth are many, and the ones that are the most important and most impactful are the top four on this list. If you've had a previous preterm birth or preterm rupture of membranes, those patients have upward of a 35% recurrence risk. Multiple gestations contribute greatly to preterm birth. And then what we've learned over the past decades is that shortened cervix, as found on ultrasound examination, particularly less than 25 millimeters, is associated with a significant increased risk of early birth. We know that there are other factors that are involved. We know that African American community has a significant increased risk. White population around 10, in the African American population up to 14 to 15. Smokers, short interval pregnancy, less than 18 months, urinary tract infections, periodontal disease, and the list goes on. There are other things, but these are things that are associated with an increased risk, but not nearly to the degree of the top four on this list. Next slide. So what do we do? How are we going to get to that lowering of our preterm birth rate in this country and really across the world? And there's been a lot of work done on it, but like I said to start with, there's just not been a lot of headway made. There's the surveillance piece, there's the prophylactic piece, and there's the treatment piece. And we're going to talk mainly about surveillance and the prophylaxis. I'm not going to talk a lot about cerclage. The last slide of the day, we'll talk about it, but I will say that cerclage placement to prevent preterm birth has not been successful. So I won't say much more than that. Next slide. So cervical fibronectin, swabs from the cervicovaginal secretions test for this substance. It's very non-specific. And it's a great test in symptomatic women because of the negative predictive value. So if you've got a patient that has symptoms of preterm labor, but their cervix is not significantly dilated, it can be a nice surveillance method to help you managing those patients. But the problem is in the low risk patients and the asymptomatic patients, the predictive value is extremely poor, so it's low. So it's not a good screening tool in the asymptomatic patients, but it certainly might play a role in some of our practices when we're dealing with patients that are more high risk. And I'm not going to say any more than that about fibronectin. Cervical length has been shown to have a nice association with preterm birth, but in low risk women, that positive predictive value is not great. And the problem is that universal vaginal scanning for cervical length not only has a low positive predictive value, but it's a high cost. It's a bit uncomfortable, and it takes more time than routine scanning that we do transabdominally. And because of the low positive predictive value and the expense, ACOG and other organizations have recommended assessment of the cervix during the anatomy scan between 18 and 22 weeks, doing the transabdominal approach. And if you suspect that the cervix is less than 25 millimeters on that scan, then proceed with an endovaginal approach. We know that a vaginal scan to look and measure the cervix is much more accurate than the transabdominal scan. So it's a good screening tool just to get the first blush, and then if there's concern, then to proceed with the endovaginal scan is appropriate. Next slide. Now, where cervical length is more helpful is in the high-risk patient that we know has had problems or is at a significant risk for preterm birth. In patients that have had prior preterm birth, the suggestion is by most of us and most of our professional societies is to consider some screening protocol. Everybody may do it a little bit differently. We do every 2-week scans between 16 and 24 weeks, looking at the cervical length. Many propose that you do this with multiple gestations because of their increased risk as well. Others do not. We do screen our particularly MODI twins and higher order multiples with vaginal scanning as well. And we can talk about that later and debate it if anybody has concerns or questions about that. The other thing that I think we really need to pay attention to is if patients come in or call in with atypical symptoms in the mid-trimester, if they have those symptoms of increased pressure, significant increased vaginal mucousy discharge, that you should always do a cervical length screening in those patients, because that patient certainly might be showing you symptoms of early either cervical insufficiency or preterm labor type changes. Next slide. So on to the prophylaxis with progesterone. Progesterone has been around for a long time as treatment, and I remember as early as the mid-80s when I did a rotation in Spartanburg, there was an attending there that utilized data from an Australian and an Israeli study that showed the use of delalutin, which was 17p, could prevent preterm birth in high-risk patients. So we used it a lot then. And it kind of fell out of favor, and then people started to look at it again. This is the study that really catapulted its use in modern day obstetrics. This study's from 2003, the MEIS trial, where they used 17 OHP, 250 milligrams a week intramuscularly, in patients with a prior preterm birth or preterm rupture of membranes. And it included 19 different sites. Next slide. And they actually halted the enrollment early because the open evaluation showed a 34% reduction in preterm birth compared with placebo, with the relative risk ratio of 0.66. And it also showed a significant improvement in neonatal outcomes with lower neonatal death, respiratory distress, bronchopulmonary dysplasia, and so forth, to 0.25 to 0.63 in the relative risk ratio. So significant improvement. Now, since that time, there have been many smaller studies that did suggest off and on. Some showed some improvement, some showed not so much. And then the prolonged trial came about in 2020. It's the post-market follow-up study, actually funded by the pharmaceutical company. The FDA supported this study. One of the problems that many people have cited is that only 10% of the enrolled patients were from North America. But the question was, let's prove in a much larger study, does 17-OHP decrease recurrent preterm birth, neonatal issues as well? And this study involved almost 2,000 patients. Next slide. And interestingly, this study, if you look at the third line from the top on both of these, preterm birth, spontaneous preterm birth less than 37 weeks, there was no difference in the treatment group versus no treatment group. Less than 35 weeks, there was no difference. And less than 32 weeks, there was no difference. So it really called into question whether the IM progesterone is beneficial for prevention of preterm birth in these high-risk patients. And this brought up a great deal of discussion that is going on today. Next slide. The next series of slides are going to have to do with vaginal progesterone. So at the same time that there was debate over the intramuscular progesterone in prevention of preterm labor, many trials have been performed using vaginal progesterone in an attempt to prevent preterm birth. And there have been varying results. The studies have been smaller, larger. This is the Cochrane database that systematically reviewed all of the randomized controlled trials, looked at 36 trials, over 8,000 women. Next slide. And this first group that we're going to talk about has to do with patients who've had prior spontaneous preterm births and have had vaginal progesterone prescribed to prevent preterm birth in these patients in a randomized fashion. And the systematic review showed a significant reduction in these first 5 studies. Over 600 women, decreased birth less than 34 weeks and less than 37 weeks, a little bit less robust at 37 weeks, but definitely less at 34 weeks. Next slide. Then if you look at the risk of perinatal complications, a significant improvement overall, lower incidence of very low birth weight babies, better ventilation, less necrotizing enterocolitis. Basically, all of the neonatal things that we look at associated with preterm labor were improved in the vaginal progesterone group compared to the placebo group. Now, one of the problems with these studies that has been voiced, and there actually are several studies ongoing right now, multi-center studies looking at a set dose of vaginal progesterone. And there's some studies comparing vaginal progesterone to IM progesterone that are ongoing. But in these studies from the Cochrane database, the doses of progesterone were kind of all over the board. So there wasn't a standard set dose. Most used around 200 milligrams. But we really do need more studies to look at a standard approach of using the vaginal progesterone. Next slide. So another area that's really been focused upon in recent years is the use of progesterone in low-risk women, but they're found to have a shortened cervix on ultrasound. And progesterone in these conglomeration of studies has been shown to have a reduction in preterm birth, both less than 34 weeks and less than 28 weeks. So if you find a shortened cervix incidentally on ultrasound between 16 and 24 weeks, the vaginal progesterone seems to have an improved outcome with preterm birth reduction. Next slide. Now, when the second trial, the post-market trial came out, the prolonged study with the intramuscular 17-OHP, there was a great cry that we should stop its use, that the prolonged trial showed that there was no benefit. And I was very pleased that ACOG and SMFM came out with a statement offering, don't throw the baby out with the bathwater. Let's look at all of the data together, and came out with this statement: consideration for offering 17P to women at risk of recurrent preterm birth should take into account the entire body of evidence concerning progesterone supplementation. So there is a huge push to continue progesterone utilization for prophylaxis in these high-risk patients. And whether that be vaginal progesterone or IM, I think that should be discussed with the patient. Next slide. And my personal bent is that the aggregate data does demonstrate benefit when progesterone is used. The data also shows that 17P is much more likely to be associated with success or lower preterm birth if it's used starting at 16 weeks. And the earlier you use it between that 16 and 18 week range, the more likely there's going to be success. Vaginal progesterone has seemed to be a little more forgiving, and the studies show as late as 24 weeks that there's some benefit in utilization of vaginal progesterone. But whether to use it and which route, you just have to discuss with the patient, and it depends on what your personal take on the data is. I think that the vaginal route is definitely not inferior to the IM, and in many ways, I think that it's probably even more beneficial. And I have certainly some personal biases why I think that might be the case that we can talk about. Next slide. And this is the best part of the ACOG practice bulletin. The bulletin on this is really pretty good. It outlines the data very nicely. But for practicing OBGYNs and for nursing and anybody who's really intrigued by this chart is very helpful, I think. If you look at the left-hand side, the cervical length on ultrasound in a singleton pregnancy with no prior preterm birth, look at the cervix with ultrasound on the routine anatomy scan. If it's normal, well, 17-OHP is not indicated in this population with no preterm birth. If there is a shortened cervix found on ultrasound less than 25 millimeters, vaginal progesterone is recommended. Cerclage has not been shown to be beneficial. There are some studies that show that if the cervix is less than 10 to 15 millimeters in this low risk group of patients, there may be some benefit. Obviously, if their cervix is dilated, certainly consider cerclage. And I did not talk about pessaries, but my belief is that pessaries have very little impact in preventing preterm birth in our patients. The next little bit, it has to do with patients who have had prior preterm births. The recommendation is serial ultrasound of the cervix. Offer either vaginal progesterone or 17-OHP prophylactically in these patients starting at 16 weeks. If they choose not to do that and you find that their cervix is shortened, definitely encourage vaginal progesterone at that point, and certainly consider a cervical cerclage if the cervix is less than 25 millimeters. Many people in this category, there's some debate whether you do vaginal progesterone versus cervical cerclage versus both, and there's no data to support either approach. So I would say cervical cerclage and or vaginal progesterone is certainly reasonable. Multiple gestations, it's basically all up in the air and depends on expert opinion and what your take on it, what your MFM feels is the most appropriate. And I'm not going to get into a lot of discussion with that unless somebody has certain questions regarding that. So I'm going to stop there. That was a lot of wordy slides. It's there for you to review. I did put those last two up. Go back to that last slide, if you would. Bacterial vaginosis screening and treatment has not been proven to decrease preterm birth, and cervical length screening for prior cone biopsies, prior leaps, and multiple DNCs have also not been shown to be beneficial. However, I think that you have to take each individual into account. If you've had a patient who has had a very large amount of cervix removed on cone biopsy or leap, I certainly think that it's a reasonable thing to follow their cervical length, but there's very little data to support management in that particular group of patients. So I will stop there and turn it over to Dr. Johnson and Dr. Dellinger